Hi, everyone. They're passing out some handouts that go along with my talk, and they're really there for your reference. We won't be able to cover everything today. I'll do my best, but hopefully I'll get you started with some information. So today I'm going to talk to you about functional cognition and perception in the stroke patient. Our goals is to identify the cognitive and perceptual functional deficits in stroke or ABI, acquired brain injury, discuss the evidence and decision-making concerning approaches to addressing cognition and perception, and describe some techniques. Oh, I have a big monitor here. This is nice. For improving functional cognition and perception in patients. Okay. So a lot of people don't know what occupational therapy is, but basically we're looking at tasks and jobs that people do in their lives. So we need our brains in order to do the things that we need to do, correct? So we identify the problems, thank you, that people are, why they're not functioning after their injury or disease. We'll either address parts of it, of the task, or all of it. It might be related to the human performance, the nature of the job or the task, or the environment. So really it's a collective synthesis of anatomy, physiology, neuroscience, kinesiology, and psychology. Okay. So we're really going to do a very brief overview because I'm sure that you folks have already kind of gone through a little bit of neuroanatomy. Sorry about that. Okay. All right. So these are the obviously different lobe areas. And if you're looking at the perfusion of the cerebral arteries, where it affects obviously anterior, your frontal, medial, middle cerebral artery, parietal, and temporal, and then PCA, occipital. But really we want to talk more about neuroplasticity. It really is basically our overall state of health, and our brains continually create and break these neural connections. Okay, as therapists, what we do is we use habituation in order to create or decrease neural responses. And our brains really are very experience dependent or use dependent, and that's why it's plastic. What you see like with stroke patients, is basically the use it or lose it is very true. So if we're not practicing or doing something frequently, we're not utilizing those skills. And our cellular recovery is basically, you know, our bodies are pretty amazing. We are all superheroes. We regenerate, we heal, okay? So we want to promote that recovery by kind of altering those synapses and reorganizing the central nervous system by what we're doing with the patient. Okay. So Brodmann basically parceled the cerebral cortex with you know, little microscopic slides, and they were able to pinpoint certain areas in the brain that is very precise in a particular function, like speech and sensory and so forth. But what we're learning more about the brain is that it can really reorganize. So we have Einstein's brain, and as you can see, he has a very enhanced parietal lobe. So it shows that he has a lot of enhanced spatial and mathematic capabilities, which totally makes sense. And a little side note, they're selling slices of Einstein's brain, which is kind of a weird thing. But and then the scan you see here is a girl with a left hemispheric area totally removed. Believe it or not, they did a follow-up with her, and she was able, her family was bilingual. She learned both languages, and she was able to recover the right side of her body. So if you doubted neuroplasticity, it does happen. Okay, and this is a functional MRI looking at cortical reorganization. This is somebody who had a nerve reconstruction from the right to the left limb, and as you can see, as they're starting to innervate the left side, you can see where in the brain we're seeing activity. Okay. So when we talk about cognition and perception, we're basically thinking, we're seeing, and we get to do. So it's our ability to interact, adapt, and function. So treatment is very straightforward. It's basically providing what they're not able to do, okay? But how do we identify the exact problem and really know what they need. So in your handout here, we're going to follow that along as I talk. The first one I have is the cognitive components description, and kind of follow along. That gives us a better idea of what we're looking at. Okay. Okay. So cognition is basically the process of acquiring knowledge and understanding. So these are all of the components. We have attention, processing, memory, reasoning, all of our senses and being able to integrate all of our senses, comprehension, which is categorization, concepts, schemas, communication, executive function, which is problem solving and decision making, and our mood. Okay. So let's talk about attention. Attention is really quite important. It's the gateway to memory. If we're not paying attention, are we even going to store it away? Probably not. So a lot of times we always say, oh, you don't have good memory. It might be related, really is the gateway. It's the attention part. So that ability to concentrate and focus, there are very different components of attention. So there's selective attention, where we concentrate with distractions, alternating between two or more objects, sustaining attention, maintaining it over time, dividing attention, responding to multiple tasks together, and then processing that information. So on your sheet, I broke up the different attention components, and to really give an example of the dysfunction that the person exhibits. For instance, somebody not noticing something on the floor, or can they complete their paperwork when somebody just put something down on their desk? Are they able to have that selective attention? And a lot of times you'll have people who you might come into a patient room and all of a sudden the phone rings and they actually drop something. And it might be a missed kind of picked up problem, is that they might be clumsy or that they've lost sensation, when actually it might be an intentional thing, okay, because they've been distracted. Or you might have somebody who is a great ambulator and someone says their name and they lose their balance. And it may not be balance related, but it might be attention related. Okay. All right. So strategies for attention, kind of limit distractions. That seems fairly obvious. Reducing their stress, fatigue, maintaining them to be engaged in the activity, because you want to maintain their attention. So you may ask them, how are you doing? Interject, ask questions, create interest and motivation, and just let them know what some of the expectations are. I'm sorry, I'm talking kind of fast here. All right. So looking at memory, our ability to recall and recognize information, short-term and long-term, okay? It takes about 10 to 20 seconds to actually store something away into memory, okay? So, sometimes we pop into a patient's room, we say, hey, this is the date, and we barely spend 2 seconds with them, and we expect them to recall that orientation question. It's not enough. So we want to make sure that they're rehearsing that information frequently. Everyone should be doing that. It helps them orient them. But we need that 10 to 20 seconds is a long time. Okay. So procedural memory is knowing how to do things, and it becomes automatic over time, like tying your shoes or riding a bike. Declarative is a conscious, intentional recall of facts and concepts, like your high school graduation. And then perspective is remembering to perform an action or intention, like a doctor's appointment. And there are other memory components like somatic, episodic, procedural, and then working memory is holding temporary information and being able to store it away for use later. So there's quite a few different components there. All right, so some strategies for memory is using descriptions, providing a synonym at the end of the sentence, having them repeat and self-talk. Again, we're trying to use that 10 to 20 seconds to store it away and encode the information. Visualization, imagery, rhymes, paraphrasing, grouping or chunking elements, creating stories, and space retrieval. Okay. Executive function is that bigger overarching ability. It coordinates everything: problem solving, planning, organization. And we need the ability to have some self-awareness in order to do this. If we don't know what's wrong or how to modify things along the way, it's very difficult to have this bigger capability. So it oversees everything and monitors for efficient productivity. Okay. So some strategies for that is organizing thoughts and environments, create maybe a tracking system for the patient, putting something in the same place, like the locations, folders, lists, developing a mapping or a chaining system. Make sure that you're facilitating self-awareness, because they can't correct a problem or make decisions if they don't know that it exists, and eliminate distractions. Okay. Reasoning is our ability to identify, interpret, and come up with a conclusion. So we want to give them information, give them some experiences so they can make good decisions. Sometimes we ask patients to do things and we really haven't provided the setup in order for them to come to a good conclusion. Okay. So the strategies for helping them with reasoning is evaluate the situation, identify and prioritize the known elements, just really consider their feelings and emotions and why, and just factor all the elements for them to come up to the decision making. Okay. And communication is our expression and perception of needs and emotions to bond, learn, obtain, and exchange information. And that comes in very different formats. It can be visual, verbal. Paralanguage is our intonation. If we're very monotone, that doesn't communicate very well. Or if we have high intonations and pleasure in our voices, then it definitely communicates something different. Nonverbal, written, and physical. So when someone's having difficulty with communication, help them identify how they feel, help them identify who they're communicating with. Sometimes people don't know who they're communicating. It's different to communicate with a child versus an adult or someone you care about. And then just help them identify the best method to get the point across. So it might be an alternate method, such as a note, email, gesturing, demonstration, a drawing, a communication board. And mood has a lot to do with our ability to deal with or process a situation. It's highly related to the limbic system. That's our instinct, our mood, our basic emotions, and our drive. So it is made up of the hypothalamus, which regulates our systems, the hippocampus, which takes memory and information and spatial things for navigation. And it actually is our save button in our brain. Okay. So that is a very important area. And our amygdala, it processes the emotion and associates it with experience so that we can make decisions. So if we had a negative experience, like I hate spiders, I'm going to associate that with an experience and I'm going to make a decision about that. Okay, so strategies for mood and coping, facilitate relaxation, maybe help them see another perspective, identify their mood or situation, and referral to somebody who is relatable to that person, whether it be a chaplain, a family member, a support group person. And I know it's talked about a lot, but address sleep and negative behaviors such as drug and alcohol use, and provide an easy way to achieve those activities and even exercise. In your handout, I also provided you with neurocognitive behaviors. Those are kind of outside of just cognition, but some tips on how you would address aggression, defiance, which we sometimes come across, hyperactivity, hallucinations, and I won't have a chance to touch on it today, but it's there for you for your reference. Okay, so a big thing is perception. I think most patients, this is missed for them quite a bit, is their ability to perceive things. So it's the organization, identification, interpretation of sensory information. So they understand and can represent their environment that they're in. So, of course, it's our ability to see, hear, and become aware of something through our senses. So, sight, smell, taste, hearing, touch, where our body is in space, and then also our social information as well. How perception really works is there's some kind of distal outside stimulus, whether it be visual, sound, or physical. And then our senses, our sensory receptors will receive it. And then our brain's going to make a mental representation of that and be able to interpret it so we can act upon it. Sensory changes can be complicated by aphasia, which is not cognition. I want to make that clear. That's a communication problem, but it also can be related to complicated by cognitive deficits. Now, sensory changes and age-related decline really distorts our representation of the world. It leads to loss of function and decline. So we want to look at mood, motivation, sleep disorders, culture, medications, diseases, behavior changes, and anything that might disrupt them in their recovery. Okay. So talking about perception, those different sensory areas, and we're looking at vision, which is also impacted by the actual structures of our visual pathway. And then auditory, which includes not only sounds, but also vibrations in our environment. And then constancy is recognizing that the same stimulus in various situations are the same. Okay, so you really understand that the difference when you're in different situations. Haptic is touch and proprioception. Okay. And then our other senses of taste, smell, balance, pain, our internal organs. These things are really important in looking at how we interact with the world. But we're going to focus on visual perception as well today because it does relate closely to cognition. Okay. You also have a visual processing handout too. Kind of this one here. Okay. So visual perception is the ability to interpret the surrounding environment, processing information that is contained in actually visual light. Okay. So we're going to see how our brains really can modify how we interpret things. So it's an example of just how mapping happens in our brain. So Andrew, could you play that first?
Take a look at this spinning ballerina. We've got a question for you, but take a second to really think about it before you answer. Which direction is she spinning? Is it clockwise or is it counterclockwise? If you're watching with a friend, feel free to ask them the same question. Got your answer? Well, if you said clockwise, congratulations, you're right. And if you said counterclockwise, I'm sorry, but you're also right. So, how can both answers be correct? As you watch the dancer, specific cells in the back of your eyes are working to detect motion, either from right to left or left to right. Since here you're right, it's Albert Einstein. Now take a look at this mask of Einstein. It may not make you a genius, but can you figure out if this is the front of the mask or the back of the mask? Got your answer? I'll give you a hint. The answer is relatively simple. Have you decided if this is the front of the Einstein mask or the back of the Einstein mask? Before we reveal the answer, let's see what some other people thought when we asked them the same question about the famous professor.
We're approaching this Einstein mask, and as we get closer, I want you guys to identify which is the front of the mask, which is the back of the mask.
Whoa! The back looks like the front.
Did you also think the back of the mask was the front? If so, that's a completely normal response.
My eyes and my brain were both playing a trick on me at the same time.
Just about everyone we showed this mask to couldn't tell the back from the front. But why is that?
The hollow face illusion reveals something that our visual system does quite well, which is to try and make sense of the world in the most typical way it can. We're used to seeing normal faces, not faces that are hollowed out. And your visual system assumes that when it gets something ambiguous that could be a face, that it must be a face.
So that kind of tells you a little bit, especially if somebody has an injury, a stroke, they really have some disruption to their perception. Okay, and we're normal and we're having trouble with this. So visual perception, actually, there's a couple things we want to discriminate, is unilateral visual inattention and visual spatial awareness. I think a lot of us have the same problem. That is not my car. But you'll notice patients who walk or they're veering to the side, they really have some spatial difficulties, or they may be undershooting, overshooting, and it's not related to their eyes at all. Their ability to analyze what they see, knowing the foreground from the background, being able to discern everything. Many of these patients will have difficulty in a grocery store or not being able to know where things are just because it looks just all one blank, messy thing to them. And then visual construction. Can they put parts together and mentally and be able to make sense of that? So this is an example of neglect or inattention. You probably have seen patients like this. Their gaze is off to one side. They can't even turn their eyes, and it's not related to a structure of their eye that's a problem. They'll eat and they'll only eat half the plate. If you ask them to draw a clock, you can see that they will only draw parts of it, and that's a common test. Okay, so you can play the next one, Andrew.
Always the right.
You must always eat on the right side, but not the left side. Just leave that.
Give her a dinner plate and she'd only eat the vegetables and leave the meat, which is disappointing because I was a cook.
So if he starts a picture, it can not fit in the paper if it gets over to the left because he hasn't left enough room.
Spatial neglect is a syndrome, that is signs and symptoms that patients most frequently have after stroke, but sometimes in forms of Alzheimer's disease, where they ignore one side of space. So people, objects, and sounds on one side tend to get ignored, and the patients who have it tend to be drawn to the other side. And this can extend to things like the food on the plate in front of them. They'll only eat food on this side and then say they're finished. It may extend to parts of their own body. So when trying to shave, they may only shave this side of the face and miss out this. See the lines there?
Split them in the middle.
Yeah, that's one end, that's the other end. Show me where the middle is. Mark the middle for me.
I was only looking at a line from there to there. And it's in the middle of my line, not the middle of your line.
So the first time I saw you, that's where you were marking this in. So patients realise something's wrong when things are pointed out to them over and over and over again. So in a way, I think for them it's slightly abstract, that they know that there's some problem on the left-hand side and they're not aware of that problem, but they know everybody's telling them they have to do something more on the left. And so they use strategies, things like that, to try and overcome the problem without.
Okay, so with unilateral visual inattention, they tend to neglect things on the right or the left side. This is not a visual loss, okay? So how you can observe the patient during their normal task is if they have no deficits, you'll see them actively turning their eyes and their head to the stimulus. If they have a partial defect, you'll see that once in a while they'll pay attention, sometimes they don't, but it's not consistent. And if they have a severe defect, you'll notice that they will, their world has tilted because they don't believe this exists. So you'll see them lean. Okay, it's not a balance problem. It's because their world is completely shifted and they think that's the middle. So you'll see them tilt their head or just have trouble. They'll walk like here because they believe it to be the new middle for them. Some of the things you can do, like the neurologist did, was a line bisection test. Really simple. You can tell they miss it every time. They can't put it right in the middle. A copying test, like draw a clock or a person. And then there's some more objective tests, a behavioral inattention test and a letter cancellation test. Okay. So what you can do for them for inattention is you kind of, their behaviors kind of tell you if it's inattention or visual deficits. People with a visual field cut will tell you, I cannot see it. It's in their language. Versus somebody who has inattention, they're like, no, I don't know what you mean. It's not there. It's much more vague in their language because in their mind, they believe this to be what is a representation of what they know. So they'll have like more of an asymmetrical searching pattern. If you put something on the table and they'll kind of randomly search, the person with the field cut will be more abbreviated and stay to the blind field. The inattention person, they really don't make an attempt to search to that inattentive side. But the people with field cut, because they're fairly cognitively intact, they'll search to the blind side. And the person with inattention they're not very accurate. They really don't care. They do it quickly versus the person with a field cut. They tend to be more precise and check for things. Okay, so treatments for visual inattention, there's a restorative approach where we want to try to improve their ability. And then the adaptive approach is just to try to help them function. We're not trying to restore that. So helping them understand their difficulties is a restorative approach. You want them to have a linear or clockwise scanning ability, having them sustain attention. You may want to kind of constrain the area that they like to go to, so it forces them to go to their neglected side, and provide multisensory cueing. It can be touch, it can be temperature, but get them to cue over to the other side. And then an adaptive approach is just really having compensatory scanning, cueing them, having them place things in their field that they can see, but that's, like I said, is more of an adaptive approach, and we want to try to restore them. Okay. So someone with spatial deficits, they're not able to see differences in position, direction, angles, or rotation. They would have trouble with navigation. You can see that looks like most people's pantries. And just placement of things, like they won't know before, up, over, to the side. Placement of things would not make sense for them. Okay. So the test for that, what you'll see is if they're correctly placing things or orienting themselves, then there's no deficit. But they're only intermittently able to do that, then they have partial deficit. And if they have a severe deficit, they are unable to, they misalign quite a bit, they twist objects, they need a lot of help. Some of the tests is the cross test, trail makings test, and judgment of line orientation test. So again, 2 approaches, restorative and adaptive approaches. For spatial relations, you want them to retrieve items based on location. For instance, get your brush on top of the drawer. Do they know that's top, bottom? Okay. Use landmarks so they can have orientation, stop at the stop sign on the left and then move your body 90 degrees. Reference cues and variations in size and orientation, and provide them with tactile and kinesthetic guidance. Now, if you're wanting to provide an adaptive approach, you want to organize things in the same place all times, put markers on locations. I love blue painter's tape. I have them mark spots in their houses and corners, doorways, because they always run into things. And it's a cheap way to help them make sure that they're safer at home. Okay. So visual synthesis, we have difficulty with discrimination and recognition of objects and features. So if something's partially occluded, like the stop sign, they won't know that that's a stop sign, okay? Or if somebody's driving you might have a very high level patient who has a visual synthesis problem. If somebody's standing next to a bush, they actually don't know that the person's there because they cannot complete the picture. Junky drawers would be difficult for them. Putting things together would be hard. So a test for that would be to kind of look at if they can see different abstract shapes. Can they see something in a junk drawer or an I Spy, game? If they have intermittent ability, that's of course, they have a partial deficit. And if they're missing things 50% of the time, then they have a pretty severe deficit. And there's some formal tests, the Hooper Visual Organization Test and the Ayers Figure Ground Test. Okay. So some similar approaches, of course. We're going to let them know that they have a problem and so they can understand their situation better. We want to provide enhanced sensory input so that they can perform better. And that would be more of a restorative approach. You can alternate the task with vision and then take the vision away to see if they can manage a little bit better. And then adaptive approaches would be kind of placing things right where they can distinguish things, label things. Use of contrast colors would help so things pop out for them, and just kind of limit how much is available for them to sort out. Okay. And this is problems with visual construction. It's the difficulty in being able to build and understand the stimulus. If we are all people who go to IKEA, we can never build it, so you can tell them to build it for you. But you'll see these people cannot figure out like how to tie their shoes, or their covers are always messed up. They don't know how to turn them around. They can't put parts together, and they might be a very high level person, but it's very frustrating for them. They don't know why they're having this problem. Okay, so with visual construction, you are looking at the synthesis and discrimination. Can they like wrap a package or arrange flowers? Those are some kind of functional tests. Can they put a lid on? Can they put a letter in an envelope? Can they put like a 3-piece sandwich together? Those would be construction activities for them. Okay. So a restorative approach and an adaptive approach, they tend to be fairly similar. But then, again, let people know. We tend to not let patients know what's going on. We kind of say, oh, you have this, but we don't give them good education precisely of what's happening. I think knowledge is pretty powerful, and people can make good gains if they know how and what to do. So, okay. I'm hoping that the treatment references I gave you get you started. I know I'm talking very fast and it's a big topic. I could probably go for days on this, but we all kind of share the same objective of improving our patients' lives. Everyone is living longer, and the brain doesn't stop at an age. It's really dependent on our experience, and we can give them good experiences that help them make these neural connections. I have an aunt who's 106 and lives all by herself. And I just saw her in San Francisco. She lives in a 3-level home. So her hearing's not very good, but otherwise she's very intact, but she's very engaged. And I really think it's her activity level. How many of you know how many repetitions it takes to make a neural connection? I don't have a prize. I only have a cough drop. But so they did studies with animals. It takes 400 repetitions to lay a pathway. Okay, so when we go in, we ask the patient to do something 10 times. Do you think that's going to be enough? Okay. So frequent orientation, especially for cognition, making them aware, let them practice when they're in the room. I know we can't always mobilize a patient, but we can stimulate their cognitive and visual capabilities on a regular basis. So the other things that will contribute to kind of more of a comprehensive stroke treatment is really understanding apraxia, which is motor planning, aphasias, and sensory deficits. And so I would encourage you to kind of see the other pieces that really contribute to the overall treatment of the patient. Okay, any questions at all? Are you ready for breaks?